right. Welcome, everybody. My name is Jenny Beck-Esme. I'm joined today by Dr. Mary McLean and Dr. Livia Santiago Rosado. And together we're going to present to you the plight of the pelvic exam, or can it really be dismissed? And we're very excited that you're here to join us. So let's get started. You are at your workstation when a new patient pops up on your board and is assigned to your GYN room. You know, that kind of dark one that's tucked in the far corner of your emergency department. Your colleague next to you groans, "Oh, not another pelvic exam. I just hate doing the pelvic exam." Well, your colleague is not alone. As you're going to see Dr. McLean discuss later, many of us are reluctant to see GYN patients and perform the necessary exams. And to understand our collective reluctance, it can be helpful to put this exam in some historical context. So we first see descriptions of the vaginal speculum in the writings of the ancient Greek physician Galen in 130 AD. And we have actually found items that are believed to be vaginal speculums in the ruins of Pompeii from 79 AD. But the modern vaginal speculum, what we're essentially using today, dates back to this man, Dr. James Marion Sims, who's often heralded as the father of American gynecology. Now, he's a controversial figure. He was during his time, and he still is today. And that's because he performed all of his gynecological surgical experiments on slave women, many of whom he purchased and kept on his property, on his hospital grounds. But he did give us some surgical tools and techniques that we're still using today, one of these being the speculum. In 1845, Sims opened up a private hospital for women in Montgomery, Alabama. There he treated the slave women of the surrounding community, and one of the problems he saw a lot of was the vesicovaginal fistula that these women were developing after they gave birth to children. Now, you have to keep in mind that this is an era when the interactions between men and women were really very strict, and that carried over into medicine as well. Doctors were not supposed to look at the genitalia of their female patients. And if you actually look at the illustrations from medical texts of the time, the doctors here are examining their patients by reaching up under layers of gowns and feeling around blindly. And so deep was their concern for not looking where they were examining that doctors were specifically instructed to reassure a female patient that he was not looking at her private parts by either gazing off into the distance or maintaining direct, continuous eye contact throughout the process. And honestly, I'm not sure which of those would have been creepier. But Sims realized he needed to actually see these fistulas if he was going to be able to repair them. So one day, while treating one of these patients, the thought dawned on him to insert the bent handle of a silver gravy spoon in the vagina of one of these slave women, apply some posterior pressure, and voila, the first modern vaginal speculum was born. He tweaked it into a device that looked like this, and then continued to tweak this initial model into something that looks a lot like the duckbill that we are still using today. And he ultimately, as I said, did come up with techniques to fix these fistulas, which was great for those women who were suffering and for women who came after them. But he did so by operating on slave women, often without the benefit of anesthesia, sometimes performing as many as 30 operations on the same woman. I mentioned that he was a controversial figure in his time, but they were not super concerned then about the ethics of his experimentation on slave women. Rather, they were concerned with the ethics of the device itself that he was creating. And now, while they recognized that they might be able to treat the diseases of the pelvis better if they could see them, they were worried that by opening up this part of a woman's body, they might turn even the most pious of women into prostitutes or sex-crazed maniacs. So why did doctors ultimately accept this tool? Well, if you think about childbirth and the care of pregnant women in general in this era, it was under the realm of midwives, which was most often done by women. And as one historian put it, the male doctors looked around and thought, hey, we should be doing that. But childbirth was seen as a natural process. So how could the medical establishment take control of the natural process? Well, of course, with tools they had and the midwives did not. So by embracing the forceps and its cousin, the speculums, doctors took control of this entire specialty of OBGYN. Now, I wish I could tell you that the dubious ethics of the pelvic exam ended with the Civil War, but unfortunately, that is just not the case. In the modern era, we've had to deal with the ethics surrounding the teaching of pelvic exams on anesthetized women without their consent. Now, there was significant public outcry about this back in the early 1900s, which led 4 states to pass laws making it illegal way back then. But then the interest seemed to die down. But the interest went away, but the practice did not go away. In a 2003 study of 400 students at 5 different medical schools, 90% admitted to performing pelvic exams on anesthetized women with unclear consent. But what's more concerning, probably even than that really atrociously high number, are the attitudes of these students. At the start of their training, students expressed concern about the moral aspects of performing non-consensual pelvic exams. But when they were resurveyed after they completed their OBGYN clerkship, they placed a lot less importance on obtaining consent prior to a pelvic exam. So somehow they were becoming less ethical over the course of their medical training, which is obviously not what we want. Now, since then, there has been a resurgence in public interest in this problem over the last few years, with many more states passing laws explicitly prohibiting this practice. So with a history like this, it's really no wonder that this is an uncomfortable exam, both for us and our patients. So do we really need to be doing it? To see where we're at on this now, let's turn to Dr. Mary McLean.
Thank you so much, Dr. Beck-Esme. And like you mentioned, it seems that emergency medicine as a whole just doesn't seem to like gynecology or pelvic exams. Case in point, a 2016 retrospective review that was published in Academic Emergency Medicine looked at 30,000 ED cases and at time intervals from patient rooming to resident self-assignment for different chief complaints. Investigators used this metric as a surrogate for resident preference. And you can see in this histogram that vaginal bleeding was the second to last preference of 76 ED chief complaints studied after controlling for age, race, sex, ESI, department census, time of day, etc. And you think to yourself, all right, well, at least it wasn't the very last category. Well, the last category was other. Ryan Radecki responded that enthusiasm, as measured by time to provider, for performing pelvic examination in the emergency department is low. And Rick Pescatore commented, it's like we'll do whatever we can to get out of the pelvic exam. With all this in mind, we'll take a 5-minute whirlwind tour of the recent literature over the past decade or so. But we first want to mention that we are still in an era where fake news is everywhere. Of course, we know that people do look for real news on sites meant for entertainment. And peer review is supposed to keep fake news out of our medical journals, but it is not a perfect filter. So with this context, let's move on to the literature. The impact of pelvic exams on outcomes was actually last reviewed in 2009, 12 years ago, which is a long time for this prominent and controversial topic. Regardless, this review by Dr. Isawarde included 43 articles studying a very specific scenario. Non-hypotensive patients with mild to moderate vaginal bleeding in early pregnancy presenting to an ED where transvaginal ultrasound and beta-HCG testing were readily available. The review first cautioned that most available research was observational and had low level of evidence, but they still concluded that the routine use of the pelvic examination is not supported by the literature. Aside from this review, a lot of newer articles have made other controversial conclusions based on underpowered or otherwise flawed study designs and inconclusive data. Many of these recent studies have focused on the downsides to performing the pelvic exam in the ED. Investigators have argued that it's uncomfortable for patients, it increases ED length of stay, and that limited supplies and resources are problems. Some studies suggest that the bimanual exam isn't even worth trying because of poor sensitivity and poor inter-rater reliability. Other studies have suggested that pelvic exam findings rarely change diagnoses or influence the ED management. On the other side, a few studies have investigated ways to make the pelvic exam a little more comfortable for patients, and that, as I see it, is the incredibly bright side of this lit review. The majority of recent studies simply question the standard of care that we have practiced for decades in regards to the pelvic exam. And this is perfectly reasonable. It would be great if we had some well-designed, adequately powered studies with statistically significant, conclusive data telling us which ED cases don't require a pelvic exam. But we simply do not have that kind of evidence yet. So, do we just keep doing what we're doing because we've always done it? Or do we stop now, arguably without solid evidence that doing so is safe? Meanwhile, some other studies assert that the pelvic exam is obsolete and unhelpful. These are strong assertions. And again, they're based on studies with crucial and sometimes multiple flaws. And are they actually valid and applicable to our clinical practice? Let's dig a little bit deeper into one particular recent study. In 2017, Annals of Emergency Medicine published a prospective randomized equivalence trial that was the largest study of its kind to date, and probably the most notable recent study. Essentially, ED patients with ultrasound-confirmed first trimester intrauterine pregnancy with vaginal bleeding or low abdominal pain were randomized to have a pelvic exam or not. And investigators looked at composite morbidity in both groups, including such metrics as unscheduled return, admission, any kind of procedure, transfusion, infection, and lots of other metrics. In this study, there were a few flaws, and we'll talk about those. First is statistical power. So their calculations suggested they needed 720 participants to reach adequate power, but they ultimately enrolled just over 200. So the results are already going to be a little bit iffy. Next is bias and enrollment. Although 1,280 patients were available during the study period, under 16% of these patients were actually enrolled. And there were many exclusion criteria, which worsens the potential for bias in this study. Some of the exclusion criteria were things like non-English speakers, patients who had their pelvic exam before their ultrasound, which in many cases is what happens, patients younger than 18, those who came into the ED outside of normal business hours, and those who declined a pelvic exam, and also those for whom the physician declined to enroll, which they could do so at their discretion. So the risk of bias was high. Last is the actual results. The observed difference in outcomes between control and intervention groups was actually not statistically significant. However, their conclusion was the study provides additional data that support the safety of omitting a pelvic exam in women with a confirmed intrauterine pregnancy on ultrasonography, unless there are specific clinical concerns such as infection or trauma. There were many reviews in response to this article. And again, Dr. Rick Pescatore weighed in and stated, for so many of my patients, I am the only step along the path between the pregnancy test and the delivery room. What if I can save even one kid from being born with chlamydia? Doesn't an open os lead to a different conversation with the patient than a closed one? So, with such controversial and shaky recent literature, where do we turn for some solid recommendations? Well, fortunately, in 2019, the Journal of Obstetrics and Gynecology Canada compiled practice guidelines via a large collaboration with other medical societies. And it mostly boils down to these 4 points, 2 of which I want to highlight. Symptomatic gynecologic complaints must be investigated with a pelvic exam. And current task force statements on pelvic exam should not be interpreted to mean it's non-contributory to care. So given these recommendations, I'll pass off the torch to Dr. Santiago Rosado to discuss what to do in the ED now.
Thank you so much. So Dr. McLean has shown us that the data supporting that the demise of the ED pelvic exam have been rather flawed. So instead of deciding to call a code, we could be asking a different question. When and how? All right, that's 2 questions. But there are some rather robust data to show us some answers, and those answers can really help us master the pelvic exam and the ED. So when? Now, ACOG's statement is kind of circular in that it says that pelvic exams should be performed when they're indicated. But they do give us some indications actually that are consistent with some chief complaints you actually see on any given shift. But let's focus on the how. So according to most definitions, a pelvic exam involves an external genital exam followed by a speculum exam, plus a bimanual exam, plus or minus a specimen collection, plus or minus a rectal exam even. But think about the definition of any exam that you do and how you actually perform it. On your real life abdominal exam, do you regularly percuss for a spleen tip, or do you really assess all 14 auscultation areas on your lung exam? Perhaps we'd be less likely to avoid or dread the pelvic exam if we thought about it like we do these others. As we practice, we really learn to customize the chest or the lung exam, the abdominal exam, selecting portions to answer specific questions. So it's time we think about the pelvic as consisting of parts that you can select, reorder, or defer. Some vaginal complaints would suggest a speculum exam like bleeding or abnormal discharge. You want to start with a small size and use plenty of lubricating gel. You want to apply posterior pressure as described, and that is because you're then opening up that posterior potential space in the rectum and avoiding anterior structures that are sensitive like the urethra. But really, you should start with an external exam because that could even dissuade you from the need to even go further to a bimanual or a speculum exam. Think of somebody with a Bartholin's abscess or an acute herpes flare. And by the way, speaking of herpes, please, please, please consider dysuria a potential vaginal complaint in women. Remember that dysuria can have a urologic or a genital source in both men and women. And since women seldom examine their own genitals, maybe we should. Now, in terms of pelvic pain, you do need a pelvic exam when you're diagnosing or treating an incomplete miscarriage that's briskly bleeding, or a foreign body, or even PID. The visualization that is allowed by the speculum in these cases can be useful, but there is some evidence suggesting that a bimanual first exam is actually more comfortable for more women. In fact, you can consider stopping after the bimanual exam. Between external inspection and the actual palpation of these key structures, you can actually answer a lot of questions, and this can be easily done at the bedside in less than 20 seconds. Now, there's no equipment required when you do this other than gloves and some lube. The patient can stay covered under a sheet. You can just bring their pants down to allow some access with hips and knees flexed and abducted, and no bare buttocks upon stirrups anymore. But by the way, you may have heard or learned along the way that you want to avoid lubricating jelly because it can alter the results of specimen collection, but that turns out not to be the case. It's not really an issue, so please be generous with it. And a gel warmer can even add an added level of comfort. Take the opportunity to even further and better customize your exam by utilizing shared decision-making. Maybe the patient has a preference as to the content or even the sequence of their exam. Ask them where they prefer their chaperone to stand. It actually adds a level of autonomy as well as modesty to the process. Incorporate trauma-informed care into your approach. So be sensitive to a history of any sexual violence, genital mutilation, or other related trauma. And engage your LGBTQ patients as far as their preferences and expectations. Make sure there are no surprises. Let them know what you're about to do, and maybe narrate the exam or talk gently through it. I feel your uterus, I don't notice any abnormal swelling. And focus on comfort. Inviting your patient to take some slow, deep breaths may sound a little hokey, but it actually does work to relax muscles and to increase the pain threshold. Also, warmth helps. So also why you want to maybe have the patient keeps their socks on. And think about language as well. So footrest sounds better than stirrups. And you really want to avoid saying that things look good during an exam because it could really be creepy or triggering. Stay with healthy. So the big ideas here, don't call the code on the pelvic exam. Resuscitate it and master it. Really incorporate your patient's preferences and autonomy as part of this. Consider starting with a quick look and a bimanual exam. It really is quick, it is efficient, it keeps the patient covered and in the stretcher, and it really answers most questions. And if you do need a speculum, consider plenty of lubrication as well as other measures to increase comfort that we talked about. This way your patients will benefit from both your thoroughness as well as your consideration.
As we wrap up, we want to leave you thinking with our main key points. As a whole, emergency physicians just seem to not like the pelvic exam. And some of this likely has roots in the disturbing historical and societal context of the exam. Recent literature is flawed and does not provide solid evidence for omitting the pelvic exam from our ED toolkit. So instead, we should focus on improving the pelvic exam experience with methods like customizing the exam to each patient's case, incorporating trauma-informed care, and warming that lubricating gel. These are the things we need to be doing now in our emergency department rather than stopping the exam altogether. Thank you so much for joining us today.
Doctors, thanks so much. My name is Casey Glass. I'm the program committee moderator. And there was one question from the chat, just people looking for more access to some of the references that you all made. Do you have a bibliography that people should look at, or maybe another website or reference that would be great for that?
I can put the bibliography up, and if they want to so they can take a screen grab.
That sounds awesome. And then another question I had is, what do you think about the emergency medicine perspective that, you know, every female patient with abdominal pain needs a pelvic exam? I think that a lot of the literature maybe is somewhat of a reaction to that perspective, and I think you bring a great cautionary note to that. How do you guys view that bit of emergency medicine dogma?
I could take that. I actually think that, you know, just like anything else, you really have to take each patient individually, right? And so I would hesitate to say that every abdominal pain, certainly pain that is sort of above the umbilicus, unless there's something like Fitzhugh-Curtis in your differential, you know, would not necessarily suggest a pelvic exam. Whereas pain below the umbilicus may be more so. Certainly when associated symptoms are suggestive, right? Like if there's pelvic pain plus discharge plus bleeding plus suspected, you know, ectopic pregnancy, whatever it might be. I think, you know, just evaluating the patient and really, again, having that shared decision-making aspect of it, of saying like, look, you know, this pain that you're having could be due to an ovarian pathology, an ovarian problem, uterine issue. I'd like to perform, you know, a quick exam just to try to examine those structures internally, and kind of go with the patient on that as well.
I'm just going to add to that because I totally agree with Dr. Santiago. And I would say that especially for any patient with female patient with lower abdominal complaints, I like to at least discuss the possibility of doing the exam with them. And the reason is I find that not all women, certainly in specific age groups, are terribly forthcoming with any GYN symptoms that they have. And so it's not until I talk about the importance of doing that exam that I might get a little bit more history from them that then will either push me, that might actually push me to really doing the exam. But it's kind of like, it highlights for them that I care about that part of their medical history as well. And I don't always hear it until I bring up the exam.
Well, thank you so much, ladies. That was a fantastic presentation, and thank you, audience, for being here. And I hope you enjoy the last day of SAEM. Thanks.